All right, let's game.
And you are visible to our currently 3 attendees.
Oh, let's give it a couple more minutes.
5, 6. Yep, they're loading in.
Good morning, good evening, everyone. We'll start in 1 minute or so to let a few people to join. Okay, good. Hi, everyone. I'm Jeremy Sugarman. Welcome to one of the MEURI's sponsored Hot Topics in Research Ethics webinar series. Thanks for joining us either in your evening, your afternoon, or your morning. We are delighted to move forward with the second in our series of Hot Topics in Research Ethics. And today we have Voo Teck Chuan, who's going to speak to us. But before I turn it over to one of my colleagues, Sharon Cower, to introduce him, I just wanted to say a bit about the program that makes this all possible. The program is a US NIH funded initiative to create a Masters of Health Research Ethics program that's based at the University of Malaya, and it's in partnership with the Johns Hopkins Berman Institute. I'm one of the co-principal investigators, along with my colleague, Dean Adiba Kamarulzaman. The Masters of Health Research Ethics program is in its second cohort. So we have had an approved program. The first cohort graduated recently, and now our second cohort is going strong. It's a full 1 year full program. The application is every year at the end of May. We do an intake every September, and it's the 1 year program. And the program hopes to create graduates who are able to engage in various aspects of health research ethics. The nice thing about this program is that there are actually up to 10 scholarships available from applicants from Malaysia, as well as low and middle income Southeast Asian countries. So while those scholarships are there, please think about us, think about it and apply. And if you want some more information about it, just search under MEURI's or go to our website, meuri.um.edu.my. So just the rules for this webinar, you should have received a notice that we are being recorded. We're recording to make sure that this is accessible to people. We realize time zones are always an issue, and we want to make sure that this is available to people who could be asleep right now, or people who got caught up doing other things. So we are recording. Once you've joined, you may have noticed that your audio and video are turned off. If you have questions, please use the chat box. The Q&A, put them in the chat box down here, and we'll try to address those in the Q&A session. Okay, so make sure to put them there. We really have saved a lot of time for good questions and answers. And so we're looking forward to this hour. I'll turn it over to my friend and colleague, Sharon Cower at the University of Malaya, who will introduce our speaker.
Thanks, Jeremy, and thanks everybody for joining us today. And I'm really happy today to be introducing a colleague and a good friend, Dr. Voo Teck Chuan, who is an assistant professor at the Center for Biomedical Ethics, Yong Loo School of Medicine at the National University of Singapore. He researches and writes on ethical issues in healthcare and in public health, with a focus on infectious disease control and prevention, and the interactions between healthcare ethics and public health ethics. He is an editorial board member of the journal Asian Bioethics Review, as well as the Springer Nature Philosophy and Medicine book series. At a national level, Teck Chuan serves on various ethics committees in Singapore. He is a member of the Ng Teng Fong General Hospital and Jurong Community Hospital Clinical Ethics Committee, the Ministry of Health Assisted Reproduction Services Working Committee, the National Healthcare Group Research Ethics Committee, the Ministry of Health Advisory Committee on Restricted Human Biomedical Research, and the National Advisory Committee for Laboratory Animal Research. Teck Chuan also has a number of positions at an international level, and he is a steering committee member of the Global Forum on Bioethics in Research. He is also a member of the Ethics Advisory Committee at the University of Nebraska Medical Center and is an external expert advisor for the Research Ethics Consultation Service for Marginalized Populations, hosted by the Faculty of Medicine at the University of Malaya. Teck Chuan has served the World Health Organization in clinical guideline development in various areas and in ethics guidance development relating to epidemics and public health emergencies. And he is currently a member of the WHO Working Group on Ethics in COVID-19. So he's really well placed to give us this talk today. And I welcome you, Teck Chuan, and I'm looking forward to hearing your presentation. So over to you.
Hi, thanks, Sharon. Yeah, so hi, everyone. It's 9 p.m. in Singapore. I'm in my office because this is where my children turn into monsters because they're tired and they won't go to bed. So I'm in the safety of my office. I'm also a member of the WHO MEURI work group, which is looking to sort of present further guidance and clarifications on application of the MEURI framework to the provision of unproven interventions during a public health emergency. But whatever I say here does not represent the group's views. So let me just share my slides. Right. Can everyone see my slides?
Yes.
Okay. Yeah, so this is really a work in progress paper that I'm developing with my colleagues from the National University of Singapore Center for Biomedical Ethics. Tamara Liesel, I believe she's here, Owen Schaefer and Roy Joseph. So it's really based on our reflections on the ethical guidance on experimental non-standard interventions for COVID-19 that we developed in response to a request from a national work group that is providing and determining guidelines for provision of all these unproven interventions. Okay, couple of months back, right? I can't remember exactly which month. That guidance has been written up. It's not yet online, but we hope it will be soon in January. And we're just using this work to sort of think about really how MEURI, or what is called the monitored emergency application of unregistered and interventional products could be applied in a setting like Singapore, and actually what really MEURI is all about. So this is what I'm going to talk about today, really our approach and challenges in adapting MEURI to the Singapore context, given our national legal and regulatory framework, and hope through this process to think about what MEURI really is, and to sort of clarify how it ought to be conceptualized and how it ought to be applied. So before I go into that, let me just talk a little bit about the broader ethical issues in the provision of unproven interventions during an emergency situation where mortality rate is high and there's no proven interventions, right? So we know there's a kind of tension between the need to sort of initiate clinical trials, well-designed clinical trials as soon as possible in order to sort of produce robust, generalizable, reliable evidence to benefit patients, right? And that's the kind of things that ought to be organized as soon as possible. And on the other hand, we know that there might be patients who will not be able to receive any sort of intervention other than perhaps supportive therapy outside of clinical trial, because those clinical trials might not be initiated because they might be excluded from the clinical trial, or simply because they refuse to participate, right? So there need to be some sort of pathways or routes for them to access in order to sort of alleviate their suffering insofar as it may be consistent with their best interest. And these are some pathways of label use, which are prescriptions outside pre-approved or licensed users, compassionate use, which is sometimes equated to expanded access. And the last possible pathway is through MEURI, monitor emergency use of unregistered and investigational interventions. Now, there's a need to sort of prevent what has been described as panic prescriptions, right? So just indiscriminate, uncontrolled prescription through off-label or through compassionate access, because this may sort of do more harm to patients without proper risk-benefit assessment, which which would be afforded if the use is given through a research protocol. It may result also in harm to non-COVID-19 patients who are benefiting from approved users by allocating resources away from this and by depleting the supply. And lastly, and importantly, it may sort of inhibit the conduct of clinical trials, because when you apply it through these various other sort of pathways, there might be a sense that it might be beneficial when in fact it's not. It may be due to the supportive care indeed. And because of these potential misconceptions, people may be reluctant to enter into trials and so forth. So there may be also of confusion about the risk-benefit profiles of all these experimental or investigational agents, right? And so there's a need to sort of control that and put them into clinical trials as soon as possible. So that is the broader ethical considerations we need to think about in the provision of unproven interventions outside clinical trials. And now I'll just talk a little bit about the task that my colleagues and I were given to do. So like many other countries, all the way back in early April, I guess, and May, we were all getting rather confused and excited about COVID-19 because of all these high degrees of uncertainty about treatments. And in Singapore, there were hardly any trials except for the Gilead trial for remdesivir. So there was a therapies work group convened by the for the Ministry of Health to think about how experimental and non-standard intervention should be given, right? And the four of us volunteered to work out the ethical guidance based on our existing legal and regulatory framework as well as professional guidelines. Our position, our stance in that document is that, you know, for very experimental, novel, innovative therapies, this should be given within the protocol of a randomized controlled trial, preferable, or any other kind of clinical trial, such as an adaptive trial design. And only in very exceptional cases may these interventions be given outside a formal clinical trial setting. So that's the position we take, and we sort of provide an outline on the criteria and circumstances and conditions for which those exceptional cases of provision outside a clinical trial may be justified. So one of the things that the clinicians were aware of, and us as well, was the potential application of the MEURI framework, right? And we know that it was developed during the 2016 West African Ebola outbreaks, right? And there in the paper, the WHO says that in the context of an outbreak characterized by high mortality, it can be ethically appropriate to provide individual patients all these interventions on an emergency basis outside clinical trials. So they listed about 7 conditions, okay? And I think one of the most important conditions is actually number 2. These interventions should be given only when it's not possible to initiate clinical studies immediately. So the correct approach, as I to reemphasize, is to really sort of think about initiating clinical trials or studies immediately before thinking about how patients who may be excluded from these trials, for example, may be given access in order to alleviate their suffering. So you can see that MEURI really takes into account various sort of things that we are familiar with, both in terms of clinical ethics as well as research ethics, right? The need to minimize risk, the need to get informed consent. And what it does is also to sort of monitor those emergency use in order to assure patient safety, right? And to share those results in a timely fashion, both with the local medical community as well as the international community to understand the effects of these unproven interventions on patients. So just to give you a comparison to expanded access, you can see there are certain similarities, but the difference between expanded access and MEURI is that, again, expanded access is only given when clinical trials are already available, right? So compared to MEURI is when clinical trials are not available, and that's when you start to give unproven interventions. So that's one important distinction. The other distinction is that for expanded access, it's usually limited to patients with serious conditions. And for my colleagues and myself, we think that potentially MEURI could also be applied to patients with mild or moderate diseases, or even given on a prophylaxis kind of a reason. And I'll share that in a little while. But these are the key distinctions between, I think, MEURI and as well as expanded access. So during the, there is actually precedent for the application of MEURI, right, in the 2018 Ebola epidemic in the Democratic Republic of Congo. So they did apply MEURI and they did give multiple novel therapies, right? And 4 of these, remdesivir and ZMapp, for example, actually went on to clinical trials. And you can see from MSF, they say that this switch from MEURI protocol to the clinical trial is actually a critical step, as it can generate the scientific data needed to draw conclusions on how effective these treatments are. So here, I think we can gather that a sense that actually MEURI is a potential pathway to support the initiation of clinical trials. So other than the fact that it should only be initiated in the absence of any clinical trials, it also provides the sort of gathering of data, systematic investigation to think about whether or not to initiate those trials, right? So, so even though the protocol has existed actually since 2016, as I mentioned earlier, it was developed in the West African Ebola context. You can see there's still quite a fair bit of confusion about COVID-19. So despite, we can see it in this article written in the Wire Science in the context of India. So even though MEURI was incorporated into the India Council of Medical Research ethical guidelines for biomedical research, it wasn't really carried out when it comes to the giving of prophylaxis, right? So it wasn't given with regard to hydroxychloroquine, right? So even though it's an anti-malaria drug, it was given to quite a number of healthcare workers without their information on what exactly it is, or without any sort of ethics review on a national level. So there's all this sort of confusion about whether or not, insofar as MEURI is parked into biomedical research ethics guidelines, whether or not it is really a kind of research activity, whether it's really a kind of clinical care, or whether it is clinical health, whether it's a kind of public health intervention, insofar as an intervention, an unproven intervention, is given as a prophylaxis. So here's a quote from one of the ICMR member, and it says that it really doesn't fall under the ambit of the guidelines for biomedical and health research, because it is a public health, and so it should be governed by other processes and other ministries. Now, because of all this sort of confusion over what MEURI really is, right? The Pan American Health Organization created ethics guidance for MEURI for COVID-19 unproven interventions applications. And in that particular document, it states rather explicitly that MEURI is not observation and research. I have to confess that I might have something to do with this, because I mentioned that insofar as it requires some sort of ethics review, systematic investigation and informed consent and all the sort of things, why can't simply clinicians who wish to provide that do it under a research protocol and call it observational study? So I think that might have led to the PAHO group thinking that there's actually some sort of cohesion, but I'm actually not that clear about it. But as you can see from the reasoning behind the PAHO group, it says that it's actually really the lack of clarity about the oversight, right? So if you look at the MEURI protocol, it just says that it ought to be reviewed by any sort of ethics committee without stipulating that that committee has to be a clinical one or a research ethics one. And so because the fact that it might be parked under research ethics oversight, people might sort of confuse and say that actually MEURI is just simply research. But PAHO is quite adamant that it is not observational research. And in fact, the oversight provided must be provided by a research ethics committee. So according to his reasoning, while MEURI does not constitute research, right, but rather access to unproven intervention outside of research, it should be guided by the same ethical principles that govern the use of unproven interventions in clinical trials. A clinical ethics committee must therefore or does conduct the review. I think there's a little bit of a non sequitur in this sort of reasoning, so far as being based on the same principles does not necessarily mean that the same sort of mechanism or ethics oversight must be created. But I won't get into that. The last sort of thing I think would be important about what PAHO says about the aspect of MEURI about the need to sort of conduct systematic monitoring and collection of data for dissemination. And it puts it solely in the space of knowledge generation, right? So the reasoning behind that is that healthcare professionals responsible for MEURI protocols have the same moral obligation to collect all scientifically relevant data that may provide information on safety and efficacy of the intervention as researchers overseeing a clinical trial. So that is actually taken from the WHO guidance for managing ethical issues in ID outbreaks that was developed in 2016. So it drew from that document to sort of provide the sort of justification. So all these, I think, at least from the PAHO's perspective, is that while MEURI is not observational research, it ought to be, it ought to come under research ethics review processes, right? And ought to contribute to knowledge generation. So it's not clear, and it's not clear to me how, whether or not this is actually feasible in the Americas context, but in the context of Singapore, when all these sort of elements are satisfied, when it actually needs to contribute to knowledge generation, that will actually be defined as research within our given setting. And in fact, our very particular act, the Human Biomedical Research Act, which governs all biomedical research in Singapore, defines any sort of systematic investigation that's intention of developing or contributing to generalizable knowledge as research in itself. And given that there are penalties and sanctions for not abiding to the Act's requirements, any clinician, I think, if they are indeed have this sort of intention in applying a MEURI protocol, would actually need to classify as observational research at least and apply to an RRC for approval. Right. So that said, because we know that in our context that many clinicians are actually reluctant to apply for RRC approval and go through the typical RB protocols. And we understand that in our context, there are actually ethical guidelines that would allow prescription of unproven interventions outside of clinical trials. We look at those documents and sort of come up with our own ethics guidance. So one of the guidance that we look at is the Singapore Medical Council Ethical Code and Ethical Guidelines. And in there, it says quite clearly that there are justifications for providing off-label prescription of medications with well-established safety profile. So insofar as in the best interest, there's a rational basis, informed consent is taken, the clinician assesses that the benefits outweigh the risk, off-label prescriptions can be given even during an emergency context. And for innovative therapies with less well-established safety profile and efficacy understanding, it ought to be given in the context of a formal clinical research. But for desperate and patients who are in dire situations, innovative therapies can potentially be given under particular conditions, right? So drawing on that reasoning, we also apply that not just to patients who are desperate, who are in severe stages of the disease, but also those with moderate diseases. And our reasoning is that giving all these particular therapies, insofar as it may prevent moderate patients with moderate diseases from progressing to severe diseases and occupy ICU resources and all of that, there is a public health justification for providing that insofar as it helps to keep the health system in a operating condition. Now, this is the specific guidance we gave, and you can see it looks a lot just like MEURI, right? So what we wrote in that document for the provision of experimental or innovative therapies, that there should be some sort of institutional guidelines to sort of determine who is in and who might be out. So it's very much like a research protocol. There should be some sort of inclusion and exclusion criteria. And insofar as a patient might be included, then a clinical ethics committee ought to be notified. They ought to give the approval and acknowledge the thing and so forth. There must also be consensus, right? Consent either from the patient or next of kin. Resources must be available to minimize risk, proper documentation, and very much like MEURI, any sort of results ought to be monitored, investigated, and then disseminated to the wider medical and scientific community so that formal scientific inquiry can be instituted if necessary. So in our paper, we went a little bit further into our guidance, and we prescribed that in coming to recommend an unproven intervention for a patient, the clinician ought to sort of outline the treatment goals. There ought to be a system for monitoring and reporting the outcomes, and there ought to be an exit criteria for the patient, right? And one thing that we came to realize is that even though it is an obligation of clinicians who are providing unproven interventions to do this, there ought to be some sort of institutional support to sort of consider requests as well as monitor outcomes. So the onus shouldn't just be on the physicians, but on the health system itself. So what we might want to sort of frame the health system is as a kind of a learning health system. So like very much like during any sort of normal situations, even during a pandemic, learning health systems, monitoring systems can be implemented to sort of understand the outcomes of unproven interventions. Now, the justification, I think, is again a balance of both a doctor's duty of care to patients, as well as a more public health justification of monitoring and reporting. So in terms of the doctor's duty of care, I think it's important that physicians themselves do not just use their own judgment, but consult with necessary professionals who might be in a position to agree or disagree with them, or consult with the clinical ethics committee, right? So to provide the kind of independent oversight that we're used to in research ethics, so as to make sure that provision of the unproven intervention is really in the best interest of the patient. In terms of monitoring and reporting, we think that the information collected may do two things. The first thing is it could either sort of adjust future treatment applications under non-trial access users, or it could sort of provide some sort of evidence base for transitioning to formal clinical research insofar as the treatment goals are met. And so that sort of transitioning is a kind of a framework and processes that can be set up as a response to the public health emergency. So this is the part where I think my colleagues and I are still very uncertain, and what I'm saying here is purely my own views. So I having reflect on MEURI both through this paper as well as my role in the WHO MEURI working group, I've come to sort of understand and think that maybe MEURI is really just a public health intervention to control the provision of unproven interventions, whether it's off-label compassionate use or even observational study, right? That may sort of really undermine the initiation of clinical trials. So you really want to sort of, insofar as it has a condition that MEURI is really only to be implemented when there are no clinical trials because of the lack of infrastructure and so forth. It sort of prevents clinicians from wanting to look at all these other routes and give and prescribe medications to patients in a very indiscriminate manner. So I think MEURI, insofar as you have MEURI that subsumes all these other sort of off-label uses. So compassionate use, off-label, or expanded access actually can be incorporated into a MEURI protocol. So all this sort of learning system monitoring can be done. And so far as that has been set up, it can actually sort of limit the setting up of clinical trials, as well as to provide the necessary evidence to support clinical trial initiation. So really, MEURI is in my conception, is about organizing non-trial users into systematic data collection and monitoring activities to make decisions on trial users, right? So as I mentioned, it's really a sort of second best alternative to the clinical trial in a context where we can't set it up yet, but we want to set it up and we want to make sure and limit uncontrolled users. So I think I might have spoken a bit too fast, but I acknowledge my thanks to Tamara, Owen, and Roy, as well as to the MEURI group, especially Nisha and Elizabeth May for organizing this. Thank you.
Okay, thank you, Teck Chuan. Question to start us off with. So the question is that if you are actually collecting data while you are actually offering these treatments under a MEURI system, and if you find a fairly significant efficacy and rate, right? And then you're saying that it should allow you to move into clinical trials. How then do you justify ethically running a placebo RCT if you already have some preliminary data that demonstrates efficacy?
Yeah, hi. So I think even those preliminary data, insofar as they are in small data sets, as opposed to a larger sample that you could collect through RCT, it could only provide any sort of preliminary evidence as opposed to robust evidence that is actually that the efficacy and safety has been well demonstrated. So even though you could get some understanding of how the therapeutics or other interventions work in a patient, you still need to move to that process. I think it's our position.
Okay, and how does that work in terms of the bigger picture of trust and trustworthiness of a system? So in a country as small as Singapore, if you are running these sort of trials and you have a certain level of efficacy and you're saying, okay, because of this, we're going to move into clinical trials, and people know and they have the disease and then they're not being offered these or they're being offered placebo-controlled trials, do you then risk losing public trust, especially when it relates to something like COVID-19 and a pandemic?
Yeah, so I think that's a really interesting and tough question to answer in the absence of empirical understanding on trust. But one possible view is that actually people may not trust clinical trials at all, insofar as if it's a placebo trial, they might only have a certain percentage, 50%, for example, of getting that experimental intervention, right? Which is what they want. And on the other hand, I think there are all these sort of potentially established fiduciary relationship with clinicians. So these might be patients who are in a hospital and all of a sudden have COVID, and this clinician is providing care all the time, and you're asking him, or the family is asking him, please provide me anything to stave off my complications and my experience. And you would think that under a kind of fiduciary relationship, physician would oblige that insofar as the benefits, there is a chance that the benefits will outweigh the risk, right? Which is dying, right? So because it's such a desperate situation, trust might actually be produced in the kind of setting. But my understanding is that oftentimes these experimental interventions, so I'm not talking about off-label ones, right? They are likely to not do any good, but also might do more harm to the patients, right? In terms of creating complication adverse effects that you do not know of. And even if you do recover, it's not even clear that it is the supportive therapy that is helping you or the experimental intervention itself. So I think what MEURI is trying to do is to create sort of a win-win situation where you are giving all these things outside a clinical trial, but you're also collecting data at the same time to sort of think about whether or not a particular intervention can be moved to a clinical trial stage. So I don't know, in that kind of sense, perhaps I think that's where a little bit of transparency about all these things may be explained to the public as part of preparedness.
So yeah, it's really an interesting conversation. So we've been fooled in the COVID space over and over and over again. So if you look at the number of interventions that clinicians thought were useful, it turns out that we collectively as clinicians were wrong. So everything from hydroxychloroquine and the like, and all a bunch of therapies, once again, we thought based on sort of lab evidence or some other hypothesis that these treatments would be effective. And almost everything that's been subjected to a randomized trial, with the exception of steroids from remdesivir with a little bit of incremental gain, some of the antibody cocktails with a little bit of incremental benefit, have turned out not to be helpful. So that's humbling. You know, I've practiced medicine for over 30 years, and that means that, you know, my intuitions about these things just isn't good. And in this case, it's not just me, fortunately. So not my abilities, but collectively. So what are your thoughts about physician wisdom, especially in a space where nobody knows for sort of a new disease how to treat? Does this framework make as much sense? And yeah, I'll stop there. I could talk about this all day, but it's your talk. So
yeah. So I think it makes sense in the sense that MEURI does have the potential to sort of limit independent physician judgment, right? And to give them also a protective space to respond to queries from dying patients or families of dying patients to just do anything for their patient, right? So insofar as they have this monitored system, they have to report to a CEC, the CEC has to approve. That sort of kind of limit the unnecessary provision of things that would not do anything but also waste potentially everybody's time. So we have even heard of stem cell therapy for COVID-19. There was 1 or 2 requests for very strange therapies. And you see that a physician will be hard pressed to think, but with all these potential systems set up, these protocols outside of clinical trials, I think it does has the advantage in terms of protecting not just patients, but also physicians. So they can say, you know, yeah, it's not me who's not approving this, it's the clinical ethics committee.
Right. So you spread the responsibility or the blame.
Right.
But also, ideally, obviously, you would get the collective input and wisdom, right, of a group that would come up with a decision. Right. It's striking that in a disease like, you know, Ebola, which is very different than a disease like COVID-19, where, you know, you almost had uniform fatality with no interventions at the outset when the framework was developed, to something that is obviously killing lots of people globally, but a smaller percentage, right? So the majority of people do well. It's a very different situation and stuff with. We're starting to get some questions in the chat. And if not, I'll ask you my questions later, but hopefully one day over chicken rice in Singapore. But let's see. There's a question from Tamara on behalf of a friend. first congratulating you and doing a nice job, and then also saying, could you explain what role public health monitoring systems could play in supporting these protocols through RECs?
Yeah, I think I might have explained that. I just learned today there's a difference between surveillance and monitoring. And so far as monitoring may be a very targeted sort of thing, I think this is what MEURI is doing, right? Whereas surveillance is all this ongoing systematic collection of data to support responses on the long term. So I think MEURI is really a public health thing. It's collecting all these clinical / public health data, and the data really is to work out the sort of internal evaluation of the safety and efficacy of these unproven interventions, at least in particular subgroups or cohort of patients who are receiving this, rather than a large population, right? As you typically expect in a clinical trial. So it might give you the kind of understanding, so that in the near future, if you do give that to any patient under MEURI, you would know how to sort of adapt that based on all this sort of data that you're receiving. On the other hand, there could be potential understanding, in the sense that because we do not know so much about the disease, we don't know what interventions might actually have some prospect of being efficacious. MEURI could help you support and provide the kind of preliminary evidence for moving into clinical trials. So it is, I think, at the end of the day, a public health monitoring process or activity. And so you need to set up the kind of health system monitoring activities to put all this data together across different hospitals. So it's not necessarily just one or two clinicians doing this, or that hospital doing this, and no one is looking at all this data. They must come to some sort of, I think, centralized national system to let all this data collectively for any sort of intervention given under MEURI.
Would you consider the experience at the Mayo Clinic with the early uses of convalescent plasma to be fitting under MEURI? Would that be a good example? So, before a clinical trial was launched on convalescent plasma in the US, there were tens of thousands of people who received convalescent plasma basically at any time of the disease, and the Mayo Clinic gathered those data and then to try to analyze those use, and it was done under a mechanism in the US to allow the use of a non-approved product, but it wasn't strictly a clinical trial. And I'm wondering if that fits, where there was some learning that happened, but not as quick a learning as might have happened. And I didn't know if that counts.
I think nobody knows at this stage. And I think even the WHO MEURI group is trying to work that out. I think MEURI has been applied even when people do not necessarily know they have been applied. And I think the question really at the end of the day is, what is the intention behind collecting the data and monitoring the data? So one understanding is simply to just sort of monitor patient safety, right? So this kind of things that we do as kind of internal audit that goes on all the time in learning health systems. On the other hand, because there's an imperative to conduct research expeditiously, that data could potentially be used to initiate clinical trials. I think that was in fact done in the DRC, as I mentioned, the Congo, during its 2018 Ebola experience. So I think it's the second arm, the beyond patient safety, that I think separates a MEURI protocol from normal monitoring processes.
Okay, great. So Eliza Muhammad has a really good question here, and writes, as we know, a clinical trial would undergo stringent assessment and to be approved by the ethical committees before its commencement. How do we prevent the potential abuse of the unproven therapies under the MEURI protocols, as it might be perceived as easier and faster to be assessed, approved as compared to traditional clinical trials? So as sort of an easier way, rather than having to, do all your applications and put up with all the changes and things like that.
Yeah, that's a good question, actually. And I think that is really the concern that the PowerHole group identified. So insofar, it's so much easier to do and characterize MEURI as some sort of observational research, or even to sort of put it as some kind of clinical practice, you might just continue to do all these sort of things without even going through or thinking about going to a clinical trial stage. But if you look at the essence of MEURI as I'm trying to sort of argue for its conceptualization, that actually the imperative is to really to think about moving to a clinical trial using the data collected. So insofar as if you look at in a given any given country, right? A big one, I mean, bigger than Singapore, you might see that some cities or whatever are already doing clinical trials. And you're saying that, no, let's continue with MEURI. But then you have to consider whether or not it's really not feasible for you to do clinical trial in your particular city, for example. If you say there's not enough patients, for example, because the infection rate there is low, that's understandable. But if you have a lot of patients and you have all the necessary setup, you should sort of initiate clinical trial immediately. So that is the most important clause, I think, of one of the most important clause of or condition of MEURI that people do not take into consideration. Yeah, and I think that's something that the PAHO document really identifies quite clearly and nicely.
Yeah, thanks, TC. That's really interesting. So following on from this particular line of thought, would you then be requiring people who apply for MEURI to specify endpoints, as in it's time specific or it's specific to a certain collection of a certain amount of data, and then whatever happens, either it has to stop or it moves on into a clinical trial? And the second question then is, for Singapore, for instance, would you be advocating a sort of a national level DSMB? And would that be something different from just a normal public health surveillance, where you would have a very specific body made up of both clinicians and statisticians and public health experts?
Okay, I have to clarify that I'm actually not an advocate of MEURI, even though it sounds as if I was. But what I'm trying to do here is really to understand it as to its potential benefits when it's being applied during a public health emergency like COVID-19, right? So if you look at MEURI, it doesn't really say what sort of ethics committee. Then it can be actually some sort of national one that's looking at it. So you're convening a lot of expertise, maybe even lay persons, right, in that particular committee to think about which patients ought to be eligible and not, and so forth, right? So you can do that. The question is whether or not you have the resources and the time. So in the context of Singapore, in the first place, there aren't that many people with the same sort of expertise, which is why you find myself being involved in so many committees because there's only so many lay persons with such expertise, right? So you might find a sort of manpower sort of thing. And the second question is whether or not you would sort of undermine the existing processes that you have. So if you're really collecting systematic investigation and you are intending to use it as a kind of a data to support generalizable knowledge, potentially you ought to sort of classify as research and undergo as a necessary RAC application. So that's one way you can actually do it. But then once you do it, I think the impetus for moving to a clinical trial is less. Right? It may not actually do. So you might want to consider MEURI insofar as you understand that this is just a stage in which you think of whether or not to stop giving that unproven intervention completely based on the data you collect through a MEURI protocol, or to move through to a clinical trial stage. Yeah.
Okay, thanks. We have a question from Lisa Kearns that says, not all participants in a MEURI program will be able to move to clinical trials. Are there accommodations for access to investigational interventions for those patients or participants? And I think you touched a little bit on that already.
Yeah, I think those patients will continue to receive under a MEURI protocol, right? Whereas new patients recruited would be recruited under a clinical trial setting. So I'll imagine that if a drug goes into the clinical trial, then existing patients will be monitored. And so they provide a separate data set, whereas new patients recruited for the same drug in the context of the clinical trial, then they would produce a new sort of data set. And then you would try to stop recruiting patients for MEURI and try to increase patients for the clinical trial so that they get the necessary sample size, right? Yeah. So I think that's also one of the danger of doing too many clinical trials in the first place. So it might actually undermine the sample size for whatever clinical trial you're doing. Yeah. So I think there has to be some sort of organized thinking, not just for MEURI, but also for clinical trials. And some sort of system must be looking at that, right? Otherwise, no scientific question will be ever answered because of the lack of patience.
Okay, well, we've had that problem for sure with bunches of small bad trials in COVID-19, right? That has undermined things globally, which is a huge problem. For MEURI, you talked about it as a potential pathway to move towards clinical trials, and the assumption there is that whatever you're trying is good. MEURI, am I understanding it correctly that if MEURI went bad, so you had some people who did quite poorly after receiving access through MEURI to an agent, would that undermine the possibility of putting something to trial because you would see someone have an adverse outcome and you wouldn't pursue a promising therapeutic? Could that also be the case that you would, it would maybe send a no-go signal either correctly or incorrectly to a clinical trial?
Yeah, that's really interesting sort of question, right? Because you will have done all the necessary groundwork, animal studies, whatever it is that you can gather on the drug, right? And understand its profile, get clearance from the expertise, and then something happened, and then what do you do then? I'm not sure how to answer that, except that it does have, I think it does present that possibility. I have not heard of that at all, actually. So yeah, but I think there is a possibility that it might happen. Yeah.
So, I mean, it underscores the need for sort of evidence-based practice. Are there any issues about diversion of medications and treatment? So one of the things we faced with hydroxychloroquine early on is everybody started to use hydroxychloroquine, and there were people who were, using hydroxychloroquine for known indications who had trouble accessing it, right? So whereas the drug was being taken up by people who didn't even need it. And it turns out they were probably causing themselves more harm than good in the event.
Yep.
So is there any part of the MEURI framework that addresses those sort of allocation or distribution questions? Stem cells, for instance, you said stem cells. We know we have a scarcity, right? Hydroxychloroquine became scarce intermittently because of all the off-label use. And ideally, you would be doing monitoring to prevent it. So I'm just wondering if that plays a role in that at all.
Yeah, we did talk about, we did publish a response to a AJOP paper on allocation issues under a MEURI protocol. And one of the things that we discussed is actually that firstly, it shouldn't hamper clinical trials. So it's very much like an expanded access program. It shouldn't sort of deter people from going to clinical trials because there's an existing pathway to get that thing. And the second thing we argue is like it shouldn't sort of undermine or deplete the supply of approved users of those products for other patients. So you have to sort of really think about all these broader allocation issues, which is why my proposal is to understand MEURI as a way to control these things. But for that to happen, you need to have an overarching view of where all these products are being given. So someone need to make the kind of assessment, whether it's for clinical trial or these other various pathways. And my argument is that even for off-label users, you can actually monitor it and share the results. So it's not just an individual person doing that thing and then the kind of results get lost. You can actually collect it, systematize it, and understand the profile of the drug.
Great. And so in the spirit of evidence-based practice, when are we going to have some evidence about the MEURI pathway and whether it's safe and effective?
Well, the product is expected to be in January or February. It's been ongoing since June, I think.
Okay.
Yeah.
So
there's no evidence for that. Yeah.
policy approaches, right? You know, about as we take new policy approaches, whether they actually help us with these issues. Okay, we're just about out of time, and I wonder, thank you so much for doing this. Did you have anything else that you wanted to say or meant to say before we close this down? Is any closing comments for the group or advice about that, or even maybe in the best medicine to take for COVID? Or no, I'm only kidding. Or stocks to buy, something like that.
Yeah, I mean, I'll be interested to hear if anyone actually think that MEURI should be just killed off. In fact, if I could share that even the progenitor of MEURI think that it should be killed off because of its potential to undermine clinical trials, just because of the lack of understanding of what exactly it is. So I hope through the paper we can actually sort of frame it as a public health thing, right, to prevent all this sort of proliferation of uncontrolled users. Yeah, so that is, I think, part of the intention of the paper. Yeah.
Well, it will be interesting to see that. And so thanks again for taking the time to do it. This is the second in our Hot Topics seminar series, as I said. We have some good ones coming up. There'll be announcements going forward for February and April. And we hope you can join us at those times. We are thinking in advance that those two will be flipping things around, where it'll be morning time in Malaysia and Singapore, and nighttime in the United States. So we're trying to be able to accommodate everyone. And so in 2021, that's the plan, and we look forward to those. When you exit the webinar today, there'll be a short link to a survey, a very brief survey. We want to make sure that we're delivering things that are of interest to you. So if you could take just a few minutes to click through to that survey and answer that, we've left enough time for that to happen, so you can be doing whatever you need to do at the top of the hour. But we appreciate your joining us, and we thank the Fogarty International Center for making this possible. And thanks again, Teck Chuan, for joining us tonight, your time. Thanks, everybody.
Yeah. Thanks, everyone.
Thanks,
Bye-bye.
CC.